Welcome, everybody. It's so nice to have everybody here today. Today, we are here with Doctors Abigail Cohen and Ariel Tabashnik from the Galynker Family Center for Bipolar Disorder. And we are going to be talking about cannabis use and bipolar disorder. Before we get started, I just do want to do a couple of light housekeeping items. This will be a roughly 45 minute presentation with time at the end for questions. We encourage everybody to drop questions as we're going in the chat box or to unmute yourselves, use the hand signals during the presentations. We really do want this to be interactive and for you all to be a part of this. This will be recorded. It is currently being recorded. It will be up on our YouTube channel, just so everybody knows. If you're not comfortable with being on a recorded Zoom, feel free to turn your camera off. If not, we always love to see everybody, so this can be interactive. As I stated before, today's presentation is about common myths and misconceptions when it comes to cannabis use for clients who are diagnosed with a bipolar disorder. And we are here with psychiatrists from the Galynker Family Center, Dr. Abigail Cohen and Dr. Ariel Tabashnik. Dr. Cohen works with adolescents and young adults who are diagnosed with bipolar disorder. She offers an individualized approach tailored to the needs of a rapidly changing young brain. She recognizes the profound creativity and growth that youth are experiencing during this time of development and is proud to support young people with bipolar disorder to manage the transition into adulthood. Dr. Tabashnik is passionate and about understanding the human condition through individual stories. She believes in a holistic approach to psychiatric care, creating a supportive and non-judgmental space to set individualized and attainable goals for adolescents and young adults and their families in managing bipolar disorder. I'm here as a moderator. My name is Amanda Falk. I am a partner and chief clinical officer at the dorm. So without further ado, we will pull up our agenda on the screen just so that everybody can see sort of the overarching themes that we will be covering. And then I am going to turn this presentation over in 1 minute. We're going to get this pulled up.
Sorry about that. Just give me 1 sec.
No worries.
To begin, thank you so much for the introduction. If I could encourage a couple of people to either unmute their microphones or turn on their cameras, I certainly invite that. Otherwise, if you're more comfortable typing in the chat, please feel free to do that as well. We'll monitor it. But I wanted to start out by kind of getting a sense of what's the first thing that comes to mind when people think of bipolar disorder. Shout it out or type it out. It doesn't have to be correct. It doesn't have to be highly technical. Just what's the first thing that comes to mind?
Self-destructive behaviors.
Self-destructive behaviors, sure. Intense manic episode. Okay, yes.
Mood
Impulsivity.
instability.
Mood instability, okay. All right, so mood instability, that's of course a big feature. So when you think of mood instability, what comes to mind with that? Well,
Mixed episodes.
okay, so mixed episodes, so usually a mixed episode refers to an episode that has features of mania and features of depression, so simultaneously highs and lows. Like somebody can be very hyperactive, not sleeping. They can have racing thoughts. They can be very irritable, and at the same time, feel very intense lows and feel suicidal. That's an example of what we would see in a mixed episode.
And in the chat, we have Nicole chimed in with out of control
outsized reactions. Amanda Luning added depression and mania. Linda Lavin added aggression. And Lucas Chavez added hypomania. So we've got some robust answers.
Absolutely, absolutely. We kind of see the whole spectrum there. Problems in school and work. Yes, absolutely. So will we be addressing bipolar 2/spectrum? So actually, you're really touching on something important, that bipolar disorder doesn't look the same for everyone. Some people really struggle with irritability, outsized reactions, and aggression. For other people it may look different. So bipolar truly is a spectrum, and a manic episode can look different from a hypomanic episode. But the biggest common feature there is increased goal-directed activity. So, I guess we're kind of focused on bipolar disorder in young people and when people are first diagnosed. So unfortunately, there is no clear, well-defined, generalizable prodrome when it comes to bipolar disorder, not the way that there is for other disorders such as psychotic disorders. Bipolar disorder can manifest as a depressive episode first, one that looks no different from the depressive episode of someone with major depressive disorder. And often bipolar disorder is diagnosed in retrospect, and that's part of what makes diagnosis so challenging at times. But I guess the most helpful thing that we can ask ourselves is, how can we recognize that a manic or hypomanic episode is on the way? And one of the earliest signs that's both a sign and a predisposing factor is poor sleep. Now, I don't know what young person gets a perfect night of eight plus hours of sleep, goes to bed at 10 p.m., wakes up at 7 a.m. every single day. I think a lot of people have varied sleep patterns, and I think a lot of us could stand to get better sleep ourselves. However,
Sorry, I was going to speak to that. That in my experience, a lot of college students, there's some chauvinism of like, oh, like, did you pull an all-nighter? I pulled an all-nighter. I haven't slept in like 3 days because I've been doing schoolwork. And that people will kind of brag about how little they're sleeping, and that there's often many college students are operating at a chronic sleep deficit. And that really like 8 hours is the bare minimum of sleep that people should be getting. Like many people need 8 or 9 hours of sleep, especially when they're learning. Sleep is how we consolidate memories. And college is just the perfect time for a manic episode to arise. Were you going to speak to that, Ariel, or?
No, that's that's absolutely right. And I think the big thing is, how long is that episode of poor sleep, and do people feel tired? Of course, people feel tired in the morning. They have a test that they crammed for. What are they going to do? They're going to down a bunch of caffeine, and then they won't be tired. But that's temporary. Where we get worried is where there's persistent sleep deprivation without someone feeling tired. And during that period of sleep deprivation, you see increased goal-directed activity that's sustained over several days. So that's how you know that we're either in a hypomanic or manic episode, or the person is at very high risk of developing one.
Yeah, and something, my spouse attended art school at RISD, and he said that like early on they got a talk from the administration, like, you guys, like, you're artists, look to your right, look to your left, like one of these people is going to be like famous, something. He said he wished what they'd said was, look to your right, look to your left, one of these people is going to have a psychotic episode. Because looking back on college, there were so many people who did things that were just kind of considered quirky at the time, that looking back on them, he was he's like, actually looking back, we should have seen that was a warning sign. Like the friend who stayed up all night for weeks on end baking pies, and then built a hot air balloon, and that was like a cool art project. And then when she built the cardboard submarine to go into the river, that's when her friends were like, uh-oh, maybe you need more support than what you're getting right now.
Absolutely. So does that mean that every creative person who, is in the zone at night and is very productive, very creative, is everybody like that going to develop bipolar disorder? No, absolutely not. But, the question is, how much is function impaired? Is there sleep deprivation? Is there an acute change from before? Some people are just very energetic, productive people at baseline. But I think an acute change from baseline, an acute increase in activity that's sustained, and an acute change in sleep is a potential warning sign.
Awesome. And I know in, one of the sort of other bullets that we wanted to cover as well is really looking at cannabis use and how that can potentially impact an individual who has a diagnosis of bipolar disorder, and also the tendency that people with this diagnosis and other mental health diagnoses as well, the tendency they have to turn to substances like cannabis to self-medicate or to numb or anesthetize or whatever the various other reasons are.
Yeah, I think that's a great point. In terms of, I think also Dr. Tabachnik used a great phrase, today's weed is not your father's cannabis, that over the past 30, 40 years, the potency of cannabis has been growing enormously, and the proportion of compounds in it has shifted over the years as well, that the two compounds in cannabis that we know the most about scientifically are delta-9 THC and cannabidiol CBD. But there are so many other cannabinoids in cannabis. There are many other compounds that we don't know quite as much about. And that back in the 1970s, like flower cannabis, the plant that was consumed by smoking, was like about 50-50 ratio CBD to THC. Over the years, it's been selectively bred to be much higher in THC. And we know that THC can provoke psychotic episodes, at least in some people. There have been studies done in Europe looking at users of hash, like hashish wax, versus plant cannabis. And at least in the European UK population that they were looking at, flower cannabis there would mostly come from the Netherlands and be selectively bred to be very high in THC. Hash wax was coming from like Turkey, where it was like more of like the plant as the plant originally developed, that's like a higher CBD ratio. And what was seen was that people who were using the high THC plant were more likely to be psychotic than people who were using the lower THC wax, even though wax is like a concentrated form. And that's something that we're seeing, is that clinically we're seeing many people become very psychotic using very little cannabis. And at least in theory, CBD is supposed to be protective against psychosis. And there are studies that have shown that as well. But we've also seen patients who became manic after using CBD that they purchased, from wherever your local CBD products are sold. And whether that's the CBD itself, or whether it's other cannabinoids in the CBD, or whether it's adulterated with something, it's not clear. But it's an area of very active investigation right now.
Another common culprit when it comes to the acute psychosis or acute intense mania that we see, especially in the hospital, is K2, which is a synthetic marijuana. It might look similar to the real thing, and it's sold as cannabis, but it's actually a completely different compound.
Why?
Yeah, I've seen it speculated that a lot of well, I don't know a lot because I haven't seen good data on it. I don't know. Has anybody seen drugsdata.org? It's a really cool website. It's run by, I don't think it's Dance Safe directly. It's a harm reduction website where people can send in samples of whatever street drugs they have anonymously. And it used to be $30, now it's $125. A lab will test them and tell you what compounds are in them. So it started with club drugs, but now they test everything. So, but very few people send in their weed samples, but I've seen a few people at MAPS speculate that weed is adulterated commonly, because if you think about it, like buying synthetic cannabinoids like K2, it's so cheap, right? It's like the difference between, oh, thank you. Thank you, Elizabeth, for posting the drugsdata.org website. If you think about it, it's like cheaper to make an artificially flavored like strawberry candy than to buy like strawberry puree, right? So like if you buy the compound and spray it on something, like that's much cheaper than actually growing the plant. So why not fuse the two together? I don't know. There isn't good data on how much cannabis is actually adulterated.
One question that came in had to do with, let's say that you're working with somebody who has a diagnosis of bipolar disorder, and they are, using cannabis either once or regularly, however many times, but it's causing symptoms. It's causing an aggravation of symptoms. How long after they stop using cannabis will those symptoms go away is the question, or will those symptoms go away?
Yeah, I can tell you, so in my experience, so it's interesting. There was a study done way back, I think in like the early to mid 80s, and that was like back when cannabis was much less potent. So like THC, like the compounds in cannabis are lipid soluble, right? So they stay in our fat stores for a longer time. Like we can metabolize things in different ways. Like our kidney metabolizes a lot of things, like our liver metabolizes things. A lot of stuff goes through us, we pee it out. Cannabis kind of sticks around for a while. There was a study that gave people a task of flying a flight simulator, and they did it sober, drunk, and stoned, right? On different days. And not surprisingly, people overestimated how well they were flying sober. Like people thought they were doing an amazing job. They were doing an okay job. And they also overestimated how well they were doing drunk and stoned, but they were aware that they were somewhat impaired. 24 hours out after consuming the substances, the alcohol intoxicated people and the cannabis intoxicated people were both impaired. But by the third day, the alcohol intoxicated people were like pretty much functioning at their baseline. But the people who had smoked cannabis had like a shift from their baseline in performance 7 days out. So that's something to consider, that weed sticks around. And just kind of, I was going to say anecdotally, in my experience, we usually allow like 30 days is sort of the magic number, like 30 days to generate new synapses, 30 days to see a major change. I would say people tend to notice the difference over the period of 30 days after abstaining from cannabis. Like, Ariel, does that?
Yeah, I think that tracks. I didn't know about that study from the 80s. That's very interesting.
Yeah, it's old.
Yeah, but still, I think that maybe in terms of, it depends what symptoms we're seeing, right? Somebody's manic episode may resolve sooner than 30 days, but there's rebound anxiety when somebody withdraws from cannabis use, and that might take 3-4 weeks. So I guess it depends which symptoms we're talking about, and it really does vary. Most of my experience has been either in the hospital or in the clinic, and there, I'm also prescribing medications, often mood stabilizing medications that are second generation antipsychotics to help metabolize.
Mm-hmm. There was another question that just came in. Are there any studies that are showing longer impact on individuals with mental health issues? From George Young. I mean, I'm not a medical doctor, but I will say anecdotally that we have clients who have a diagnosed bipolar disorder. They're thriving. They're doing really well. They're not using substances. They've been stabilized on medication that works. Like you found that magic, sort of cocktail, which sometimes can take time with different clients to find the right medications that work specifically with them. and they're feeling good, and they're feeling so good that they're like, you know what, I bet you I can like be a normal kid again, quote unquote, and I'm just gonna like go out and smoke and drink with my friends, just like on this one Friday night. And for some clients, it just takes like that one time of doing it, and all of a sudden it's like, oh, all of that work and stability, like they immediately see the emergence of symptoms again. And even though they stop, they don't go and continue using the marijuana or the alcohol. And again, I don't, you all can speak to the medical explanation of this. Just resuming taking the same meds that they were taking before, or continuing, like it's just not, it takes a while before it starts working again. And sometimes even little tweaks have to be made again. What was working before doesn't work the same now, so tweaks have to be made. And it's like, for some, not for all, it can really be a major setback that's longer than a month even, I've seen, which is why it's scary. It's like for some clients, they can go out and smoke once and they're okay. And for others, they go out and they smoke once and it's just, it's not.
Absolutely. You know, the guidance that we give often, because you're right, it's very difficult to predict. Can one person smoke once and be okay, but another person is guaranteed, no matter what medications they're stable on, they're guaranteed to have either a manic or a depressive episode after even smoking once? The guidance that we like to give is treat it like an allergy. If someone is allergic to shellfish, it doesn't matter if they eat 100 oysters or one oyster. You want to avoid those oysters because they're likely to cause a bad reaction potentially.
Yeah.
Yeah, I've seen time and again patients who have bipolar who are doing really well, who are stabilized on a medication regimen, were starting to tackle some of the issues in their lives, and then it almost sounds like some kind of like "don't do drugs, kid" ad, but it really is that way, that they use cannabis once and go into a psychotic episode that it can take 2 weeks for that to clear, you know, and with some high potency medications. And that's one of the something I've observed with the clients who I've worked with for a long time is that harm reduction, right? Some of them continue to use cannabis, and but at the same time, we work to try to address symptoms so that to improve their functioning, so they could do the stuff they need to do. As they cut back on the cannabis, we can cut back on the antipsychotics, and that's something I've advised them. And I've seen some clients who really don't like their medication and they're really committed to cutting back on the medication. They're like, okay, fine, I'll cut back on the weed. And as they cut back on the cannabis, they can scale back on their medication and take a much lower dose. And so I've interpreted that to me for some of the patients, the antipsychotics are counteracting some of the negative effects of the weed. So
there's a question here, just since we're on the
yeah.
topic, there's a question here about the effects or interactions of cannabis and lithium, lamictal, or SSRIs. You know, I don't have a mechanistic answer. I don't know that the mechanism of action when it comes to chemical drug interactions is clear. But in terms of what we see, for example, with SSRIs, one of the indications for SSRIs is to treat anxiety. Well, a lot of people will say that they self-medicate with cannabis because it treats their anxiety. So I'll ask, oh, okay, so you're not anxious anymore at all if you're smoking every night. They say, well, no, I'm still anxious. That's why I keep smoking. So that's rebound anxiety. So you would need a higher dose of SSRI, or potentially no dose of SSRI can really counteract the rebound anxiety that's happening. So I think of cannabis as kind of doing the opposite of what the medication is trying to do. Hence what Abby said, you need higher and higher doses that you otherwise wouldn't necessarily need if somebody is abstinent from cannabis.
Yeah. And
that's kind of how I think of drug interactions. It's more drug counteractions.
Danielle is asking, is it possible to determine if cannabis-related psychosis is due to a genetic predisposition to bipolar disorder or just bad luck?
If you find an answer to that, let me know. I haven't seen any evidence teasing it apart. When I worked on the child inpatient unit, we would be cautiously optimistic that when kids came in with a psychotic episode for the first time after using cannabis, that it was just a one-time substance-induced psychosis, but then seeing the same kids over and over again, including one kid who got admitted for cannabis hyperemesis syndrome, like cyclic vomiting, who he had dyed his hair a different color, like a very bold color. And so I didn't recognize him at first. And he was like, "Hey doc, your skin cleared up." And I was like, "Oh, thank you." Like, you know, but yeah, but he got admitted again psychiatrically like a number of times. So it's not clear. The initial thought years ago was that like drugs don't make people bipolar. People have like a bipolar predisposition. If they take drugs, it can bring on a bipolar episode earlier. Like it's just not clear.
I think we all know that it certainly is not going to help.
Yeah.
That we can definitively say. This is also a really important question. We're getting this question a lot from parents and from our clients as well, is how do we address the legalization of cannabis with a person taking a psychotropic medication or like any effect? You know, I will say that there's lots of things that are legal that aren't necessarily good for our health, especially if we have other conditions. You know, if you have diabetes, you know, donuts are legal, as is ice cream and a lot of other wonderful sweet treats. And you just might not be able to safely have those things because you have this condition. It's sort of like the allergy analogy that Dr. Tabashnik was talking about. Like if you have this allergy, it doesn't matter if it's legal. Like it's not something that your body can process in a way that's safe for you. So,
but it definitely does pose a challenge. You're right. Not only because legalization means that younger people can access it more readily, but also there's less of a societal stigma. And you know, we're not here to discuss whether we agree with it or don't agree with it. I think regardless, it's just important to acknowledge that, you know, the answer really is psychoeducation here, because a lot of people will understandably have the thought that, well, you know, if this was illegal for many years and now they legalized it, it must be safe. Maybe it's not as bad as people thought. But you know, we're seeing more and more now that that's not the case. And you know, I do reassure a lot of my younger clients that there are things that we know about cannabis now that I didn't know in medical school or even at the beginning of residency.
Christy, you had your hand up before, and I think it went down, but I want to acknowledge that it was up.
Sure. I was going to type in the question: what length of time being med stable after psychosis and or bipolar diagnosis would you link to cannabis use? Would you consider starting to taper down off meds or not? So maybe someone who is taking their recovery seriously and is like, okay, I'm not at risk of using right now again, but I would like to consider seeing if this is something that might go away or not. Like, kind of curious what your thoughts are on that, Ariel, or any of you.
A really excellent question. I think it's very case by case. You know, the big thing is, what evidence of stability in other areas of people's lives is there? You know, my philosophy to prescribing or to medication changes in general is that we make one change at a time, whether we're going up on a medication or going down on medications. And I count life changes or big life events as changes as well. For example, if somebody is about to move out, is about to graduate from college, is about to start a new job, you know, I might hold off on making that change. But if everything else is stable, if there is no evidence of a depressive or manic or hypomanic episode, if we haven't seen any of those prodromal symptoms before an isolated instance of substance use, that's, that's a situation where we can consider it. Of course, I want to make sure that they have very, very close follow-up, that they're being followed by ideally the same doctor that knows them and has known them over a period of time. We at the center, we take a team approach. Everybody has a therapist and a psychiatrist for the most part. So a lot of our clients are also in groups, and it's really helpful to have more than one pair of eyes on the same person. So that close follow-up is really, really helpful for that.
Yeah, I completely agree. I think the team approach is really important. So at a place like the family center or at the dorm, where people have robust support, where they have, say, like a therapist who knows them well, who's been working with them for a long time, who can check in about how they're doing and notice if there are like any changes, see if their motivation to continue abstinence is waning, and also keep an eye out for signs of mania, for like changes in sleep, for as Dr. Tabachnik said, the increased goal-directed activity, like if their speech starts becoming more rapid, because that's generally our perspective, to use the least medication that's effective. Like to use as little medication as possible to help people to be in a stable place where they can achieve their own personal goals.
So do you ever see that the bipolar that you think has been triggered by cannabis, do you ever see that go away? Like, do you think it goes away, or do you think it's there to last?
It depends very much from one patient to the next, I would say. I guess, sorry, can you clarify the question?
Sure. So the bipolar, now you've made the diagnosis and you believe it's cannabis-induced, and so maybe medication has been started. Do any of you, believe that bipolar diagnosis maybe would go away from because it was cannabis-induced, or do you see that is there for life now?
Oh, so to clarify,
bipolar.
Yeah, to clarify, I think I said something confusing earlier, that on the child inpatient unit, when we see kids who become psychotic after using cannabis, and it's their first psychotic episode, and there doesn't seem to be a history of bipolar, we either call it like typically like a substance-induced psychotic episode, and hope that it's just a one-time thing and that they do well. What we've seen is that some of the same kids come back again and again, and whether that's due to a bipolar diathesis, like a predisposition that's activated by the weed, is unclear. I would say, like, if someone just has one psychotic episode and it's related to cannabis use, that wouldn't be bipolar per se. But again, it's hard to say, it's hard to say who's going to have one episode and who's going to have recurring episodes.
We like to take a really thorough history, and I think there are no definitive answers, but I also look at the family history. Is there a family history of bipolar 1, bipolar 2? Is there a family history of psychotic illness? Is there a family history of substance use disorders? And in somebody whose first degree relative had bipolar disorder, I think it's more likely that I would treat that as bipolar disorder rather than just substance-induced mania, which is a separate diagnosis. Of course, it's very, very difficult to distinguish sometimes.
Yeah.
I think that's the core of the question, though, right? Is how do you differentiate between a co-occurring sort of cannabis use disorder and bipolar disorder versus a sort of substance-induced or cannabis-induced, like psychosis, or like how do you make that differentiation? And it's tough. I think it becomes easier over time, right? If there's one episode following like a night of using psychedelics or using cannabis, and that's it over the course of 10 years, like you kind of have your answer. But if over the course of years, there's multiple episodes, that's,
Thank
Are
you.
there also depressive episodes, for example? Although you don't need depressive episodes to make a diagnosis of bipolar 1 or 2, but nonetheless.
Eddie and Gabriel. Eddie, I think I saw your hand first. Eddie Atkins.
Yes, how you doing today? This is a great topic, and thank you for taking my question today. So I work here in the District of Columbia, and some of the things that I'm seeing is a lot of young people not only smoking marijuana, but they lacing it with Molly, and the Molly here in the district is bad. It's the synthetic cathazone. So we're seeing a lot of episodes, first episode psychosis, as well as a lot of young people who have depression or on medication for depression, but still self-medicating with marijuana, and it just exacerbates their symptoms. What's going on with their substance use?
Mhm.
Yeah, I think you brought up a lot of points that people who are struggling with mood symptoms will often seek out things that they think will help them, right? Like, and people will use cannabis. Some people use it for anxiety. What we've seen and what's shown in studies is that over time, baseline anxiety levels increase with chronic cannabis use. And yeah, I also like that you pointed out that a lot of kids, it's polypharmacy, right? They can combine cannabis with I didn't know cathinones were big in DC. See, I'm learning a lot today. Yeah, I think it's really hard. And yeah, it's interesting. There was a recent study, because I know it's going to take me a while to find the reference for the old study, but I can give you guys a reference for a new study. So there was a study, like there was a poster shared at last year's Society for Neuroscience, looking at people with bipolar who do and don't use cannabis, and looking at their cognitive function. And it seemed that people who were cannabis users performed a little bit better on some cognitive tests of like executive function, but it was like very specific tests. And I don't know what other confounding variables they are. Maybe like my speculation is that people with more severe bipolar may have more incentive to stay away from cannabis. I don't know. But that the authors hypothesized that it may be having an effect on dopamine, which kind of like logically makes sense, right? Like drugs that are rewarding have some kind of dopaminergic properties. So yeah, so it makes sense that people would be self-medicating, and yeah, even with the downstream like negative effects.
Yeah. And affect regulation or mood regulation, regulating one's lability, is very anxiety provoking, and people who struggle with that will often self-medicate to kind of take the edge off, so to speak.
Mhm. Gabriel, did you want to unmute?
I would love to. Hi, everybody. Very, very happy to be here. Thank you for your participation in this conversation. I am someone who is diagnosed bipolar 1 and was more diagnosed later on in life. Was wondering if you've seen, as your clients have grown over the years, if there's a difference between cannabis use while they were younger versus the effects of cannabis use while they become older. And if there is any difference between what we've previously discussed in this conversation to when those individuals start growing up a little bit more and a brain is more fully developed. Just wanted to see if you all had any perspective there.
You know, I don't have the personal longitudinal experience to tell you anecdotally across my own patient population. I know from the child and adolescent psychiatry research that there's strong evidence for changes in the developing brain with cannabis use, which is why ACAP has a statement that with cannabis legalization, they're strongly advocating that it not be legal for people under age 23, approximately when the prefrontal cortex is finished developing. That it's hard that cannabis legalization, that it has some very positive benefits, that there are communities that have been targeted with unfair policing of like cannabis criminalization. And so from a justice perspective, there are definitely some benefits. What we've seen also is that cannabis use is rising among kids as like accessibility increases. And so finding a balance of like decriminalization with legislation to help regulate cannabis so that it's not so easy for kids to get their hands on, so that consumers, if they choose to use cannabis, know what they're getting. And it's not like a total mystery, because even in the states where there is legislation about cannabis testing, it looks like the data that's on the package is often wildly inaccurate. Yeah, so generally, we do see the earlier people start using cannabis, we do see some degree of like cognitive impairment that can come with the cannabis use. And that's another reason for kids to use as little as possible.
Have you all noticed, this is an important question that came in, have you all noticed cases where cannabis use can be medicinal for the more, quote, mild bipolar or bipolar 2 if legally and consistently dispensed?
You know,
I would say the less THC, the better. But Dr. Cohen, I'm not sure what you have seen.
yeah, I haven't, and I was really optimistic that CBD would be like some kind of panacea. Like, but there's a team at Mount Sinai. There's like a really fantastic research team led by Yasmin Hurd, who's like a rock star in the neuroscience world, looking at the endocannabinoid system and the effects of CBD on humans and like animal models. And I had hoped that CBD could help prevent psychosis and like, you know, do my laundry. And I haven't seen any really great benefit from, or really any benefit at all from medicinal cannabis, but I can't say definitively that there isn't one, but I haven't observed it.
One more question, and then I don't know if we want to do a little bit of a case study, at least maybe just give one quick one that people can comment on, but there is one more question. Does dopamine have to do with why cannabis may cause a psychotic episode? Not sure if either of you want to address that.
You know, I don't know the answer to that. I think, I mean, many antipsychotic medications act on dopamine, right? So I'm sure it's a part of it. There are other dopaminergic drugs that don't cause psychosis in the same way. And the endocannabinoid system, I'm totally not doing it justice. If you guys are interested, you can search for Yasmin Hurd, and there's a researcher at Yale, my colleague Anahita Basirnia, who I'll send their names. They do incredible work. They look into the endocannabinoid system. It really involves all the parts of the brain. Like, it's one of the most complex systems. It's one that neuroscience is only grappling with recently. So that's a very complicated way of saying, I don't know.
Is it purely dopamine? No, because as you said, there are a lot of substances, including sugar, that act on the dopamine system.
Right. Did you all want to do one quick case study and just sort of to bring to life some of this, the impact of cannabis on an individual with a diagnosed bipolar disorder?
Yeah, I'm thinking of one client who is someone who had bipolar disorder, bipolar 1, and had recently come out of the hospital, and he was like stable on his medication. It was like a joyful reunion back with his family. He had like robust support from his family. They were really happy to have him back after a pretty long hospitalization, and he did really well for a couple of days. And then he walked like 3 blocks to his local legal weed store and bought the Delta 8 THC that they were selling there. That's legal. You can buy it in New York at like, I don't know, bodegas. And the guy became very psychotic and was like burning things in the backyard, and the family called 911, and it took a while. It took about 2 weeks with medication to get him sort of like back to normal, you know, but like where to be less paranoid. He was like very paranoid about his family, very paranoid about everybody. Obviously, like having the cops called on someone who's paranoid is like their nightmare. It's not a fun thing for anybody. Families aren't happy to call the cops on their loved ones. So I think it is a difficult situation, and when we keep seeing again and again where people, you know, I think it's something that people who work in substance use or harm reduction are familiar with. The like, I just want to be a normal kid. I just want to use this once, like this one time will be okay, and then oftentimes it's not okay, and it's a really hard phenomenon. Yeah, I was wondering, let's see, in terms of opening it up for questions, because I thought, yeah, thank you all for coming, and thank you for your thoughtful questions and observations.
Does anybody else in the audience have any experiences or case studies or questions specifically in working with young adults with this diagnosis and using substances, whether it's cannabis or other substances that they want to share or present for us to all sort of comment on and think about? I know Caitlin said that she's worked with youth who shared that they noticed their eyesight getting worse after they quit smoking.
Yeah, I'm really curious about that. I haven't personally encountered that, but if you ever want to check in offline, I'd like to learn more about that.
I will also disclose that so I use past tense, but it was nothing that like went into a deep discussion, and it was during the intake with that client. I am curious to know like if like anybody has observed any other like clients with bipolar or like after smoking have noticed any like physiological differences as well.
Yeah, I've noticed some like almost neurological things. Like when you were commenting about the eyes, like droopy eye, even changes in gait, like listing to the left, almost like psychomotor retardation, and kind of that lasting a while longer than being high. And then, you know, is that waning? So that's why I think I was kind of curious about you guys' thoughts on the how much of the mood dysregulation and psychoses might wear off, or is it truly like this is a medication for life piece? Because watching some of the neurological pieces seem like they're wearing off, and of course it could be something else that's going on. I mean, there's always an and, or it can be an and as opposed to an or.
Very often.
Yeah, I've noticed some of that.
Yeah, and cannabis stays in the bloodstream for a while. Like, you know, drug tests can test positive for up to 30 days out. So
30 days certainly for somebody who smokes regularly.
yeah. And I see a question from Nicole about what's worked in convincing adolescents that smoking is not a good idea. So there are a number of different approaches. I think motivational interviewing is really great as a skill set. In terms of my experience, I think finding out as much detail as possible about how people use and why they use and what they get out of the experience, and finding out what maybe doesn't work so well for them, whether it's like it's expensive, you know, it's like having to sneak around and their parents disapprove, or like you know, getting in trouble at school, or it can be any number of different things. helping them find their own motivation. And for a number of my patients, it's been that, well, if you cut back on it, you can cut back on your medication. And for many patients, that's been a very potent motivator. But the financial motivator is often a big motivator for people.
Yeah. I think also, you know, especially with the teenagers, that the reality is that, you know, we are in the age, and have been in the age of fentanyl, and more and more we're seeing people smoking cannabis that is laced with fentanyl. And this is just a reality today that didn't exist, you know, years and years ago. And it's important to be really honest with teenagers about it. Teenagers don't respond to like these like just say no campaigns and like these like fanatical, untrue fear tactics. Like they see right through it. You need to be honest, you need to be upfront, and you need to be real. And the real truth is that if you're buying weed off of the street, you don't know what's in it. And there could be fentanyl or other things in it. And a youthful experimentation can end in death or overdose. So if you're going to use, what you need to do is you need to go out and you need to get fentanyl test strips. You need to test everything before you use. You need to have Narcan on you, around you, and you can't use alone. And once you explain all of this to them, sometimes they're like, ugh, is it really worth it? Like, I have to do all of that. It's sort of like how people would say, but if you teach kids how to have safe sex, they're going to have sex. No, like you're going to protect kids from, if they decide to have sex, from getting STDs and from getting pregnant. It's the same thing with this. If you're honest with them about everything that they need to do and the dangers associated in a truthful way, some will say, it's not worth it. And the ones who do decide to use will hopefully use in a safer manner that doesn't, you know, end in death. So there was a great article written in the New York Times recently about speaking to your kids in the age of fentanyl. Really great article.
Yeah, thank you, Amanda. I think that's a great point. Yeah, you never know what has fentanyl, and having fentanyl test strips is really important, because I also like to share the drugsdata.org website with teens and college students, young people that I work with, because it's real data, right? Like it's not like it's just what is, you know, what's on the street, and you can look at it and empirically almost all Adderall that's sold on the street is crystal meth at this point. You can see almost all cocaine has levamisole in it, and it'll just show you, like, you can look at the data and see in real time all the different adulterants that are out there. And it's a part of, you know, like it's a part of developing adulthood, is like taking responsibility for oneself. So like, you know, people who are growing and individuating and becoming more independent, you know, maybe that involves getting the fentanyl test strips to test what they're using.
I'm mindful of the time. It's about 4 minutes to the hour, so we will wrap up. If people have questions after the fact, please don't hesitate to reach out. We will get you some answers in writing. Thank you all for being here and for participating so actively. And we hope you all join us for our next event, which is on April 20th, which will be a CE credit event. And we will be presenting on chronic suicidality in outpatient settings. So please, we welcome you to join. It is free and it is a CE credit event, and we will be sending out invites to everybody. So thank you. Have a wonderful afternoon, and we look forward to seeing you all again soon.
Thank you so much. Thank you for hosting this. Thanks to everyone for your participation. I really enjoyed this discussion. And
yeah, thank you so much for organizing this talk, and thank you for all the important work that you do. So
thank you all as well. Thank you.